It was made by another dentist who moved interstate. Porcelain chipped off in the region of 11 and 21, and he has a meeting today and needs it to be fixed urgently. He occludes edge to edge. So in this picture, the bite is not even given. But the question mentions that he occludes edge to edge. That means there is a biting discrepancy. Basically, there is a traumatic bite. So, when there is a traumatic bite, it's but obvious that any restoration that is given is going to get chipped off. So, let's see the question again. A male patient presented with a chipped porcelain 3-unit PFM bridge. Now, when you have to understand one concept here. PFM is porcelain fused to metal. Now, see, in order to make you remember this concept easily, this is how it is. You know what is an arranged marriage? Arranged marriage means marriage between two different people, two strangers, two people who don't know each other. Different people, basically. So, porcelain and metal are two different things. So, their combination together is called as adhesion. A for adhesion, A for arranged marriage. Okay. So, when porcelain is chipped off from the metal, you would see this. You see, you can see the metal of the porcelain. So, porcelain has chipped off from the metal. So, this is called as a adhesion defect. Now, what is a cohesion defect? Cohesion defect means porcelain is chipped off from the porcelain. Cohesion means couple means two same people, two people who know each other. So, couple, cohesion, C for couple, C for cohesion, is cohesion fracture is when porcelain is chipped off from the porcelain. Now, for example, if you look at this small tiny area, don't see the metal out here. See this tiny area, and you can see that only the porcelain is chipped off, and you can just see the porcelain beneath it. You cannot see the metal beneath it. So it's basically just of the fracture of the porcelain layer. Hence, it's going to be called as a cohesion defect. But now in this picture, if I say in this entire picture, what is the defect? Then it would be adhesion cohesion defect. I hope this concept is clear. Now, when this concept is clear, you can answer the following sub questions very easily. Understood? So, let's go back to the question. So, there is chipping off, and he has a meeting today. There is no pain, but he wants the bridge to be fixed, and he has an edge to edge bite. Now, first, what is the most probably main cause for this defect? See, the question mentioned he occludes edge to edge. Now, let's see the options. Improper framework probably could be the reason. But what is the question asking? What is the most probable main cause for this defect in the bridge which is given in the picture? Improper framework can be an answer if the question did not mention about his bite. Then I would be going with that option. Unfavorable bite is the correct answer here because edge to edge means traumatic bite. Bridge design, okay, not that great. Hard biting, yes, but that is what unfavorable bite is a better answer because it's edge to edge. Hard biting can be anywhere, it doesn't have to be only in the front teeth. Thin porcelain, that can also be a reason. So, when the question is saying the most probable main cause, meaning again it's that type of the question where all the options are correct. But you have to choose the answer which is the highest priority given the scenario. Understood? What is the name of this defect? So we just went through this concept, right? Adhesion means arranged marriage, means between two different things, that is metal and porcelain. And when there is a defect, it's called as an adhesion defect. And in this region, don't look at this metal thing, only this area. The porcelain has chipped off from the porcelain itself because probably it wasn't compacted that tightly. So it's an adhesion cohesion defect. It's not an abrasion defect. But sometimes, the picture can just show the porcelain chipped off from the metal. It won't show porcelain to porcelain chip off. In that scenario, it would become the adhesion defect as the answer. Or if the picture is showing you only porcelain to porcelain fracture, then it would be a cohesion defect only. So you cannot mug up. You have to see the picture. And to not be confused between adhesion and cohesion, remember the example that I've given you of arranged marriage. Arranged means two different things, cohesion means a couple means the same thing. I hope this will stay clear in your head. Now, if you want to repair the fractured porcelain in the chair, what will you do? Now, this you'll have to mug up because we etch the porcelain with 4% hydrofluoric acid. But for how much time you etch with? Well, it's 5 minutes. And then you restore with the composite. But if it was given 9% hydrofluoric acid, then you would be etching it only for 1 minute. Okay, so you have to remember the concentration, 4% for 5 minutes and 9% for 1 minute. Understood? How would you prevent similar fracture in future? Now see, why did the fracture happen? Because he was having an edge to edge bite, so there is a traumatic bite. Now, ideal treatment would be an orthodontic correction, but if that can't be done, then we have to do something to avoid his biting. Now, to do that, especially at night, you can use a splint, a night guard, you know, because in the daytime you cannot use a splint. All the other options won't work. You give a zirconia crown or you give a proper framework design. Still, if there is an edge to edge bite, there would be constant trauma happening. So you can give a splint like when the patient, is in relaxed mode, not talking, even during the house, when he's at the house and there is not much talking required, like coming back from the office, he can wear a splint. So that would be the right answer. Now for a new bridge, if you wanted to construct high strength metal free bridge, what material would you use? See, metal free meaning they want you to use one single material. Feldspathic is porcelain. Procera is porcelain. You can make a full porcelain crown, but porcelain is basically glass. It looks very shiny, but it is not so strong. And the question is asking you to construct a high strength. Okay. Zirconia, on the other hand, is a very high strength material. Have you seen blocks of zirconia? The those machines which mill zirconia from the block, it makes a crown from the block. See, you have to understand the basic concept how porcelain is made. Porcelain, if you just go on YouTube, see how a porcelain crown is made. It's basically powder which is compacted with hand, and then it's put in a furnace to be burnt so it melts and forms a nice glazed layer. So it's like layering technique, which is pretty manual. Zirconia, on the other hand, is a block. It's a tightly compacted block of a material which you can cut, and then a crown is made out of that. So any day zirconia is more stronger when the options are given, which are technically the same versions of porcelain only: feldspathic, procera, sintered alumina. So this is a pretty easy question. And when you have such an easy question, most probably it would be an unmarked one. I hope by now you know what is unmarked question. So out of 280 questions, 40 would be unmarked, meaning even if you answer it correctly, the marks won't be counted. So don't become too happy if you find such a very easy, question served to you. It's probably unmarked. This question is probably given so that you feel confident and continue with the exam. But anyways, it may be marked also. But this is a pretty easy question, so please don't make it wrong. Great. Now we move on to SBQ2. A 60-year-old patient with Parkinson's disease. You know what is a Parkinson's disease? If not, go Google up. Has been having problems with a complete denture, worn over a mandibular partial denture for the last 6 months. Okay. So he has a maxillary complete denture, and and mandibular there is a partial denture, probably a distal extension, meaning the lower anterior teeth would be there. Now the denture becomes loose in function. Loose in function meaning when he's biting, when he's chewing. It is not loose when he's not biting and chewing. That means that is what the sentence means. The denture becomes loose in function. So when they say the denture becomes loose in function only, it means retention is not an issue because it's stable otherwise. Okay, which means it's fabricated properly, but there is problem in biting. The previous dentist had no luck with constructing satisfactory new dentures, and so the patient has been booked in with you for 30 minutes for new primary impressions. Okay. Now, what is this red spot in the upper ridge? This is what they are talking about. This is incisive papilla, which has become like a balloon. It is not some abnormal structure. So remember the anatomy. Explanation has been given, so you can go through it. By looking at the clinical situation, you recognize there is a combination syndrome. What is a combination syndrome? Combination syndrome is when there is a complete upper denture. In the lower arch, there are anterior teeth present from premolar to premolar, and molars are missing, so there is a distal extension denture. Now, what happens in this scenario? Because lower anteriors are natural thin, when they keep on hitting the upper denture, artificial teeth, they cause more resorption of the upper denture, upper ridge rather, residual ridge resorption it's called as, and it will also cause the tissue to become flabby. That is what combination syndrome is. So when the tissue starts to become flabby, the denture, which was made according to the previous measurement when the tissues were not flabby, is not going to stay stable. And the moment the lower teeth are going to hit the upper ones, the denture is going to become loose and it's going to fall off, and there'll be a ridge resorption. Now, maxillary ridge resorption happens how? It happens labially. So there would be a nice labial undercut, and that would be an undesirable one. So, what is the main factor to the changes of the combination syndrome? An undesirable labial undercut. I would like you all to read combination syndrome. I want you all to read Christensen's phenomena. Please write it down. Stop, pause the video, Google combination syndrome, or go to your textbook and read about it so that you have a better understanding of this, because it can be asked in your exam both in part 1 and part 2 also. So the answer to this is an undesirable label undercut. Understand the pathophysiology, how it is caused. I have given you a short brief, but again, pause the video, go read about combination syndrome, come back to the video and start listening again. Okay? Though I have given you an explanation, but still, go. What is the most significant difficulty that you will face in fabricating the lower denture? See, the lower anterior teeth are present. That means the bone support is good there. But the molars are missing, and you have given a distal denture. Now, when the molars are missing, the alveolar bone resorption would be there in that area. So, automatically, the anteriors where the bone, alveolar bone is present, they are going to look as if they are over erupted. Not only that, they actually become over erupted because in the upper denture area they are hitting the denture, and then there is constant ridge resorption happening. So the more the ridge gets resorbed, the more the lower anterior teeth are in a search of a contact, and they will keep on over erupting. You get my point? So the more the lower incisors over erupt, the there is more difference in the level of the alveolar bone of the lower anterior region and the lower posterior region. So when you go on to make a denture, to form the occlusal curve of Spee becomes a massive destructive, you know, stage, because it would be a very sloping kind of condition. The anteriors are like fan shape, and suddenly there would be a big dip when you're going to put the posterior teeth. So in such a scenario, then what we have to do, we have to extract the lower anteriors and then construct a proper lower denture, because making a denture becomes impossible. So that is what this question is asking. What is the significant difficulty that you will face in fabricating? you know So the option F, that is problem in recording video due to Parkinson's, is a difficulty, but it is not the most significant difficulty. You understand? So over erupted lower incisor becomes the answer of choice. Oops, I pressed a wrong button. Sorry. Let me go back. I was in SBQ2 and yeah. Now, what is the reason for the denture to become loose during function? See, they are the key word here is function, okay? It the question also mentioned and this SBQ is also mentioning the denture becomes loose only during function. It's not loose otherwise. So when it becomes loose during function, function means what? Eating. Eating can be straight biting, it can be lateral excursion biting, okay? So, unfavorable palatal anatomy is not the right answer. Involuntary muscle action, not the right answer, because if that was the right answer, then the denture would be loose all the time, not only during function. Decrease in saliva, yes, he may have decreased saliva, he may have xerostomia, but again, that would cause the denture to be loose at any point of time, not only during function. The only option here which gives you during function is interference on lateral excursion. Increase OVD means increase in vertical dimension. Again, increase in vertical dimension is not a functional thing. If the patient opens the mouth, then there is no vertical dimension. Like there is a massive gap, so the denture can become loose at that time also. But it's not becoming loose when the patient is yawning or something. It's becoming loose only when the patient is eating. Eating means direct chewing or lateral excursion, and that is how it becomes the right answer. Treatment plan includes removing the over erupted anterior teeth, the lower anterior basically, which is what I was explaining earlier. Patient had undergone hip replacement 1 year ago and he has no complications so far. What will you do before performing the extraction? Okay. So the anterior teeth are over erupted and there is no infection. So basically it's a simple extraction case. Now the patient had undergone hip replacement. According to therapeutic guidelines, please go ahead, read it again if you have forgotten. After 6 months, there is no need for any joint replacement basically. After 6 months, there is no need for any antibiotic prophylaxis. And here the question mentions 1 year ago it was done. So definitely there is no need for any antibiotic prophylaxis. So let's see the options. Prescribe pre-procedural and post-extraction antibiotic cover, not needed. Give pre-procedural antibiotic cover. I would have chosen this option if the question mentioned he has undergone hip replacement 2 months ago, or 4 months ago, or 5 months ago. But the question says 1 year ago, so no. Consult the orthopedic. Not a wrong option, but here, straight and simple, no prophylaxis is required. SBQ3. A 67-year-old lady with a complaint that her denture has never seemed right from the day it was fitted. She's not happy since day one. She's dissatisfied primarily with her upper complete overdenture. So it's an overdenture. What is an overdenture, people? Overdenture is the one which is given over the roots of the teeth. Now, why this is given is sometimes the roots are nice, or you can't extract, or the patient doesn't want to extract. So that's an overdenture. She can wear the denture in the morning, but by about 3 o'clock in the afternoon, it becomes too uncomfortable. She likes to take it out. So basically, she is comfortable wearing in the morning. But as the day progresses, it becomes uncomfortable. Why is that? Think, why is that? Because the denture is in use. At night, she has taken off the denture, so she is not having an issue. Morning, she just starts to wear it, and by afternoon, she's so uncomfortable that she has to remove it. So, something is happening when she is wearing it. Now, what can be that something? It can be a very sharp border, or it can be that when she closes her mouth, there is increased video which is stretching her muscles. Okay, there can be other reasons as well, but these are the two main reasons that can be asked in the exam. But the patient is happy with the retention and fit of the denture. Meaning, when she's yawning, it's not falling off. When she's laughing, it's not falling off. It does not move during eating. So that's great. So there is no problem in the stability of the denture. She reports no problems with her lower teeth. The TMJ is free of clicks. So why the question is telling you this? Because the question wants to tell you that the TMJ is fine and there is no pathology out there and no muscle tenderness. You notice that the patient has slightly open lip posture when she is seated in the dental chair. So when they are mentioning the TMJ is free of clicks and no muscle tenderness, they mean the muscles of the TMJ. They don't mean the muscles of mastication, so don't get confused. But the next sentence itself says that the patient has a slightly open lip, meaning she cannot close her lip when in a relaxed position. That means something is very big in her mouth, and that is the denture. There is slight redness of the palate under the denture bearing area, but the ridge is not tender. No bleeding on probing around the canine roots and no detectable sinus. So basically, they are saying that the teeth are perfect and there is no pathology. The occlusal plane is relatively even. The denture appears clean and without obvious defects, and there is a definite postdam along its posterior margin. Definite postdam meaning the margins are very good, it's retentive, it's stable, it has a good suction. So, unless she's biting, it's not giving her any problems, okay? Now, from the patient's history, what do you think could be the reason for her chief complaint? Hands down, even before saying anything, it's increase in vertical dimension, which is equal to decrease in freeway space. Okay, decrease in freeway space only will happen if there is increase in vertical dimension. Freeway space is 2 to 4 mm normally. It's present when dentures are there. When it's decreased, that means there is increase in vertical dimension. When there is increase in vertical dimension, the mouth is stretched and it hurts. How large should the freeway space be? 2 to 4 mm in the premolar region. If the patient was complaining of pain on eating or pain on the whole ridge, this would suggest, okay. Now the question did mention that the ridge is fine, there is no redness over it, and there is no pain on eating. Now, guys, when is there pain on the ridge? See, the teeth, when we arrange in complete denture, we arrange it directly over the ridge. We don't tilt it buccally or lingually because we want 90-degree, that means absolute perpendicular force of biting over the ridge. Because if you are going to put lateral forces on the ridge, it's going to resolve way faster. And we want a stable occlusion and maximum biting capacity. So we want the forces of mastication to directly, like straight away go to the ridge. So if there is a problem in the occlusion, then there would 100% be pain on the biting over the ridge. So the question is asking you, if at all the patient had complaint of pain on eating on the ridge, then what it would suggest? Then it would suggest there is problem in the centric occlusion. See, denture delivery problems is one hot favorite topic of ADC. Okay, because there are a lot of old people in Australia and in a lot of Western countries actually. See, their lifestyle is good, so they age really nicely, and there are a lot of people who are above the age of 100 years. So definitely a lot of people who are above the age of 60s and 70s, and they lose teeth due to one of the various reasons. So as a general dentist, you will be constructing probably a lot of complete dentures, even if you have made that in your country or not, doesn't matter. Or at least you'll get a lot of people who have had complete dentures and would come to you. So at least basic correction you are expected to do. Otherwise, of course, you can refer them to prosthodontist. But basic things you're supposed to know. And I understand you may have just fabricated 3 or 4 complete dentures in your BDS life. That's all right. You can study about it, right? So, denture delivery problems. Search PowerPoint presentations and SlideShare. Pause this video. Go. Read. Read all about what sound problems happen when the palate is placed too far, too narrow, when the teeth are placed too palatally, too labially. F, V, T sounds, when are they affected? what is a narrow arch denture, what is a high arch denture, when there is a stability issue, when there is a retention issue, when there is pain on the occlusal ridge. I know it may seem like a long list, but if you're going to read it on a daily basis and imagine it, you can search for PowerPoint presentations, animations over YouTube depicting all of these scenarios. Then you will be in a better position to remember. I did the same thing. I just went on YouTube, I Googled with pictures as to what problems can happen if there is a problem in a certain area of the denture. So when I see the pictures, it better registers in my mind. Like I can imagine it well. So if somebody says, you know what, there is a combination syndrome, immediately in my mind, text will not come in my mind, black and white structures don't come immediately, an image will come, an upper denture, lower teeth and lower distal extension. This is the image it would come. Like I always see, when I say a name, for example, say I say George Clooney, immediately you will think about that Hollywood actor. You won't think of anything else. I mean, there can be hundreds of people with that name, right? But as soon as you imagine, there would be a good picture, because brain links things with pictures, and the more you imagine, the faster you can answer. And this is what ADC is looking for, a fast, correct answer. Understood? So let's go ahead. So pause this video, go read about problems of vertical dimension, what happens when it is decreased, what happens when it is increased. When it is decreased, problems like Perlichet or angular cheilitis, that would happen because there would be folds of the mucosa where saliva is going to get accumulate and eventually yeast infection develops. That's why angular cheilitis. That is when the vertical dimension is decreased. And when vertical dimension is increased, there would be stretching of the jaw muscles, creating pain. Exactly the case scenario. The patient wears denture in the morning but becomes very uncomfortable by afternoon. Now, difficulty in becoming accustomed to a new denture design can be experienced within the first 3 months. Now, this you have to remember. Patient with increased vertical dimension, your management will be remake it. You cannot grind the occlusal surfaces of the teeth because you will make it flat. See, as it is, the denture teeth don't have the exact occlusal anatomy as the permanent teeth. They come into varieties. Sometimes they're absolutely flat, sometimes they would have a 30-degree cuspal inclination, sometimes a 60-degree, but not like 100% replication of a natural teeth. So if you're going to flatten that out, don't expect that the freeway space would decrease. You are creating more occlusal problems, and you should never do that. So the only way to correct this kind of a thing is you have to remake the complete denture only. Coming to our last SBQ of today, a 38-year-old man presents with a missing anterior tooth, fractured upper central incisor in a fight. So he was in a fight. The patient attended a hospital at that time, and there it was confirmed that there were no head or maxillofacial injuries. So the question is trying to tell you there is no injury otherwise. However, the patient also sustained injury to his adjacent teeth and therefore underwent root canal treatment of the left maxillary central incisor, which is there in the picture. He was advised to follow up with a local dentist. However, as the affected teeth were asymptomatic, he did not seek the treatment sooner. He appears motivated to improve his oral health and would prefer a fixed option for replacing the missing tooth. So apparently the tooth has avulsed out. He is smoker and has generalized tooth wear and generalized gingivitis. Okay, not the kind of patient you would want in your clinic, but there it is. So following a prevention and stabilization phase, the plaque scores reduced to 12% and the periodontal condition improved. The patient sought treatment for gastroesophageal reflux and reduced the frequency of intake of cariogenic and erosive foods and drink. Guys, do you see this scenario? The scenario itself was such a long to read, and there were so many points to remember. And now the SBQ also, the first SBQ also is so long. So you see, your time duration to answer this question has significantly reduced. These are the kind of questions that are going to come, and you will get exhausted question after question with such big, big scenarios. So you need to train yourself to solve more and more questions so that you don't get exasperated on the day of the exam. Like, okay, fine, I'm expecting this. Yes, I can go through it. That will should be there. Yes, I can do it. The patient sought treatment for gastroesophageal reflux and reduced the frequency of intake of chorionic and erosive foods and drinks. Endodontic treatment of the upper right lateral incisor was provided successfully. On reassessment, the patient was considered a suitable candidate for a restoration. What are the definitive replacement options for the missing upper right central, considering that he has repeated trauma and a history of parafunctional activity and he is not ready to quit smoking? Okay. They are asking about a definitive replacement. Now before we see the options, let's see the conditions that we have been given. First of all, what are the definitive replacement options? It can be an implant, it can be a fixed bridge. These are the only two definitive ones. He has repeated trauma. Now when you say repeated trauma, meaning he's going to keep on getting into fights, and a history of parafunctional activity. Parafunctional meaning he might be having bruxism or grinding. And he's not ready to quit smoking. When you say he's not ready to quit smoking, means giving an implant becomes pretty difficult. But let's see. These are the conditions, and our two definitive options are either bridge or an implant. Now, when I have these two options, and in my options I have both these options. So see, cantilever is out of question. It will fall down as he's having parafunctional habit, and it's not a definitive treatment. So cantilever options are option A and D, so I remove it. Single tooth implant is a very possible scenario. A conventional fixed bridge is again a very possible scenario. But now, since the question has specifically mentioned that he is not ready to quit smoking, I'm going to go with option B. Because for an implant, you have to stop smoking for a while. And if you won't stop smoking, then giving an implant becomes a risk of failure, which you don't want. But giving a fixed bridge, that is, taking support of the lateral and the other central, and then giving a bridge, that may fail again because he's having history of parafunctional habits and repeated trauma, but that would be more stable and more reasonable, seeing that he doesn't want to quit smoking at all. So I would go with that answer. If my question would have said that he is ready to quit smoking, or he has quit smoking recently and does not intend to start again, then I would have definitely gone with the implant. So again, do not ever mug up any of the ADC questions. Always think of possible scenarios the same question can be asked, because your answer would change given the same options. Understood? Study casts were made, but study cast record cannot benefit. So when we make a study cast, what picture in your mind should come? It comes the plaster of Paris, or the gypsum white, a maxillary and mandibular teeth, study model. So in study model, what can you do? You can record the occlusion, yes. You can see the baseline for the future tooth fairy, yes. It can be used for a diagnostic max at 100%. But can you select the baseline of the shade and the color of the teeth? No, they are all white. It's plaster of Paris, it's gypsum. You cannot see the color of the tooth. So this is like a very simple dished out question to you, again, which can be unmarked. So don't become so happy if you're marking it correct. And please do not mark this wrong. If you're marking this wrong, my God, go drown yourself in, a glass of water. This is a very simple question. So do not make it wrong. Now, the intraoral scans shown below of the prepared teeth can be used to determine all of the following except. See, when the question comes like except, you should get extra vigilant, because the mind is used to finding what is wrong. The mind is always used to seeing the options in which everything is correct and only one thing is wrong. So when except questions are asked, meaning most of the options would be right, which is not what our brain is going after. Our brain wants to pick up what is wrong. You get my point? So the intraoral scans can show everything except. Ari, again I clicked on a wrong button. Let me go back again. We are on SBQ4. Yeah. Can you see an undercut in the intraoral scan? Yes, you can. Intraoral scans are very good for that. Have you ever done an intraoral scan? If yes, you know you can see that. If not, then I would suggest go on YouTube, type videos on how to take a scan, and you can see a scan will show you such beautiful 3D live images, you know. Can you measure the measurements of the tooth reductions? Can you do that? Yes, because of late people take scans and directly submit to the lab and the crowns are made. Assessing the path of insertion, yes, you can do that. Interocclusal space, well, see, you can check interocclusal space, okay? You can do that when you take a biting scan, which we do for ortho purposes, you know, when we take a biting scan, even for crown purpose, you know, you're making a bridge or something. But in this picture, they have not shown a bite scan. So I cannot see an interocclusal space. For interocclusal space, I need my both upper and lower scans. You understand? So an intraoral scan can show you interocclusal space, but this particular scan shown in the picture cannot. So that becomes my answer. Now, the disadvantage of the CAD CAM in comparison with conventional impression include all of the following points except. So, basically, the question is asking what is the advantage of the CAD CAM over the conventional impression? But they have reworded the question to trick you, to confuse you, telling you that all of the following are disadvantages of CAD CAM except, meaning what is not a disadvantage, meaning what is the advantage of the CAD CAM. So I'm going to solve this question keeping in mind this sentence. The advantage of the CAD CAM over conventional impression is artifact due to optical stretching that affects full arch accuracy. Is that an advantage? No. Artifact is not an advantage. It's a headache. Preparation may need extra reductions more than the cast reduction. Is that an advantage? No, anything that needs an extra reduction is not an advantage. The finished product has less aesthetic than the hand layered ceramics. Is that an advantage? No, less aesthetics is not an advantage. The patient can observe and appreciate their work more. Is that an advantage? Yes, it is definitely an advantage. Because CAD CAM is computerized, you can immediately show to the patient this is how it's gonna look when the crown is prepared. That is an advantage. So that becomes my answer. I hope this is clear. So whenever the question is asking you such double negative words, you make it positive. Two negatives is positive. So the question was the disadvantage and accept, meaning the question is asking you what is an advantage. So that becomes very easier to solve. Understood? And the last question of today is CAD CAM of the provisional restorations using a chairside mill includes all of the following steps except. So CAM is basically computer assisted milling. That is CAD CAM basically. So computer assisted milling of the provisional restoration using a chairside mill includes all of the following except. So what are the steps? So all of the following are the steps. So which is not a step? So I'm going to approach my options keeping in my mind which is not a step. Selection of the appropriate material block is a step. Yes, it is a step. I mean, on what the crown is going to be manufactured. So, of course, selecting a block is a step. Positioning sprue position in the thickest position of the restoration away from the interproximal contacts. Correct. This is a step. So, I'm looking for which is not a step. Sending design to the mill loading block and closing mill to start milling. That's a step. Yes, of course. If you don't close the mill, it won't start milling. Chair side milling of restoration, a removal of block and separation of the milled restoration from the remainder of the block by sectioning sprue. Yes, that is a step. Superimposition of the preoperative scan onto the preparation scan. No, that is not a step. You already had a preparation scan, right? So, what is a preoperative scan? See, preoperative scan is the one which you took a scan before preparing the tooth. Now you have cut the tooth and you have prepared it, and now you have scanned it, and on that scan, you are going to prepare the crown. So, why do you need a preoperative scan to superimpose on the prepared tooth? The preoperative tooth could have been fractured. Now, if you would have taken a scan of that and you're superimposing on your prepared tooth, you're going to get a fractured crown. You don't want that, right? You want a proper crown to be built up. So you don't have to superimpose any preoperative scan. In fact, you don't even have to take a preoperative scan. You can directly just prepare the tooth and take one scan and be done with it. So option E becomes the correct answer of choice. So there it is. And we have discussed all this, and we will further go and discuss the rest of the questions in another two-part video. So I hope this is clearly understood and it's fresh in your mind, and all the topics that I've told you, go please read about it. And if there are any doubts or questions, just email me or message me and I'll get back to you with that. Have a good night, guys, and the countdown has begun. You can do it. Let's go back to studies, okay? Have a nice night.